So this is a talk about hyperventilation, and we're going to be covering a few things. We're going to talk about what is hyperventilation. We're going to talk about what causes it, the signs and symptoms that manifest when it's there, and then we'll talk briefly about the treatment. First of all, what's hyperventilation? Well, hyperventilation is breathing too much. So it's alveolar ventilation, getting too much gas exchange in the alveoli that is exceeding our metabolic demands. So we're blowing more gas through there than we need. Hyperventilation technically is a combination of tachpnea, which is breathing fast, and hyperpnea, which is breathing deep. So breathing fast and deep is hyperventilation. If you take a look at how that would look on a chart, eupnea is our normal tidal volume, so we're normal amount of in and out at a normal rate. The tachypnea is fast, the hyperpnea is deep. Add them together and you've got hyperventilation. What causes people to breathe fast and deep simultaneously? Why do people hyperventilate? Could be a few things. One of the things that could cause it, one of the main things that causes it is hypoxemia, so a low amount of oxygen in our blood. And as the blood travels past our brain tastes the blood and realizes there's not enough oxygen in there. In reality, what our brain mostly tastes, primarily in a healthy patient or healthy person, is the level of carbon dioxide and the pH, and then the third thing it tastes is the oxygen. But when our balance of carbon dioxide and oxygen and our pH is thrown off, our brain goes, that's not right. And if we're getting a lot of acidity in our body because there's not enough oxygen going to the cells, then the acid goes through the brain goes, too much acid, more breathing, and we start to breathe more deeply. And if we are in a very acidotic state, then our brain will just keep on telling us to hyperventilate until that acidotic state is gone. So usually when we're hypoxemic, our SpO2 monitors will show low to indicate that there's not enough oxygen in the blood. We can be misled by that. In the case of carbon monoxide poisoning specifically, the hemoglobin in our blood is saturated. It's very well saturated, but it's saturated with carbon monoxide as opposed to being saturated with oxygen. So one of the things that I constantly tell students and put on quizzes and tests and stuff is, what does an oxygen monitor, the SpO2, actually measure? And it doesn't measure the amount of oxygen in your blood. It measures the saturation of the hemoglobin. It could be saturated with carbon monoxide. We don't know. So it's better to call it a saturation monitor than an O2 monitor because it doesn't selectively measure O2. Anyway, it's a bit of an aside. So when we see people who are hyperventilating, one of the things we want to rule out is something really pathological and dangerous and acute that could be really harming them as a cause of the hyperventilation. Here's a list of things that could be causing it, pulmonary embolism, pneumothorax, blah, blah, blah. I can't memorize lists. I always have trouble with that. So I have to change it into a different sort of version. So I think about it like this. Let's go from the outside inside and think about different systems. What are the things that happen in our environment that could cause us to hyperventilate? The obvious one is if somebody sucks all the oxygen out of the room, you're going to have a hypoxic environment. A hypoxic environment means a hypoxic human. So if I stick you underwater, you're going to have at least the desire to hyperventilate. If you actually do hyperventilate while you're underwater, that's going to cause a lot of problems because you're going to aspirate a bunch of water. But if I put you in a hypoxic environment, you'll hyperventilate. If you're exposed to something that causes an anaphylactic reaction in you, you're not going to get enough air in because you're going to have a swelling airway, so you're going to start to hyperventilate. Drugs or toxins that you ingest or have injected, those can cause hyperventilation, especially if there's something that causes metabolic acidosis in your body. And if you're too hot, we can hyperventilate as a cooling mechanism. Things can go wrong inside of our head that can cause us to hyperventilate. So a brainstem injury, brainstem being where we control most of our automatic functions like breathing, our heart rate, our vasomotor tone, all those things are done down in the brainstem. So if we have a brainstem injury, for example, a stroke or raised intracranial pressure that pushes our brainstem down in through the foramen magnum, the only big hole in our skull. In fact, that's what foramen magnum means. Foramen means whole, and magnum means big. So as our brainstem gets squished down the big hole at the bottom of our skull, it gets squished and doesn't work properly anymore. Heat stroke, anxiety, or voluntary. And voluntary is a dangerous assumption, which we'll talk about later. But people can voluntarily hyperventilate. Just voluntarily hyperventilated. So we can do it. But it's a dangerous assumption to make. In the heart, acute coronary syndrome, wherever you are in the spectrum, unstable angina all the way to cardiogenic shock, that can cause hyperventilation. Problems in the lungs with oxygen exchange, so a problem in the vessels around the lungs, a pulmonary embolism, or a problem with the lung parenchyma itself, like a pneumothorax or pneumonia, or problems with the lumen inside the lungs like asthma or bronchospasm of some sort, that can all cause hyperventilation. And finally, problems inside our body. So a metabolic acidosis like diabetic ketoacidosis. If we're anemic, we're not going to be able to carry a lot of oxygen inside our blood because we don't have the red blood cells to do it. So our tissue inside our body is going to become hypoxic because our blood isn't delivering enough oxygen. Inflammation, sepsis, systemic inflammatory response syndrome, or multi-organ dysfunction syndrome, when our body starts to shut down because we're experiencing whatever sorts of problems. And pregnancy can cause hyperventilation as well because we're relatively anemic in pregnancy, and because the fetus is obviously using oxygen as well, and because the lungs are compressed, and because we can have vena cava syndrome. There's a whole bunch of things that can lead to it in pregnancy as well. So hyperventilation can be caused by a lot of things. This is an important slide. If you're a paramedic student or a paramedic clinician or a medical clinician of any sort, this is a reasonable thing to expect you to be able to reproduce. This is your differential diagnosis of hyperventilation. So you should be thinking about all these things, which means you should basically memorize these things when you're presented with a hyperventilating patient. What does a hyperventilating patient look like? Let's talk about physiologically what's happening, and then you can see highlighted in orange there what's going on. So the first thing is we increase our respiratory rate and we increase our respiratory depth. When we do that, we not only suck in a lot of air, we also blow out a lot of air, and we blow it from deep in our alveoli. We're going into our reserve volume, and we're blowing off that CO2 reservoir that we normally keep in our lungs. So the amount of carbon dioxide in our alveoli starts to decrease. We exhale it and we decrease the amount of carbon dioxide that we have. That leads to like a negative amount, not a negative amount, but a low amount of CO2 in the alveoli, which means more CO2 can offload from the blood into the lungs. So because we blow off the CO2, our blood offloads more CO2 into our alveoli, and our blood ends up being hypocapnic, having low CO2 in it. When that happens, the bicarb in our blood combines with hydrogen and forms more CO2. As that keeps on going, we eventually start to run out of bicarb and block up our hydrogen. So the hydrogen is sort of sequestered inside the blood, which means less hydrogen means we become more alkaline. And if we follow this chart straight down, you'll see that as we become more alkaline, the alkalinity drives more calcium into the blood proteins. And that decreases the amount of calcium that's actually available in the blood. And we use calcium to trigger off our depolarization in our cells. It's part of the depolarization process. So our cell membranes become more unstable. And when they become more unstable, we get spontaneous vasoconstriction, so our blood vessels vasoconstrict, and that causes two things. It causes something called tetany, which is a contraction of our muscles, especially in the hands and in the feet, and that's called carpopedal spasm, and you see people doing this. They also start to get this happening in their face as the face contracts, and so you walk in, you'll see someone going and it's a very typical presentation for somebody who's hyperventilating, the carpopedal spasm and the facial spasm as well. They also get paresthesia, which are the pins and needles. So they get that subjective sense of the tingling going. In fact, I can feel that a little bit from doing the hyperventilation now. So I get a little bit of the pins and needles happening. And if you continue to hyperventilate, you actually your vision starts to shut down to a tunnel vision, and eventually you'll just pass out. So if you take a look down the other branch of this flow chart, you see the alkalinity causes vasoconstriction. As we vasoconstrict, we cerebrally vasoconstrict, so the blood vessels in our brain shut down, and as they do, we get that syncope, and the pre-syncope is that sort of feeling of I'm going to pass out, and then the syncope is the feeling of passing out. So the big things you see in hyperventilation, the signs and symptoms, are obviously the respiratory motion of hyperventilation. You see the carpopedal spasm, you see the facial tetany going on. They'll describe, I'm getting pins and needles. They'll be confused as they're pre-syncopal. I don't know what's happening. Their vision is shutting down, so they may not track you as you come in. Usually when paramedics walk in the room, people go, wow, paramedics, and they look at you. If they don't even look at you, it means possibly that the vision's shutting down, they can't see you, and they might eventually just pass out. So that's how we get our signs and symptoms. So hypocapnia, as a result of hyperventilation, may lead to paresthesia around the mouth, hands and feet, restlessness, dyspnea, pain, vertigo, carpopedal spasm, and eventually unconsciousness. That's from the Queensland Ambulance Service Clinical Practice Guidelines. Queensland's the state I'm in right now. So here's an interesting study, clinical and laboratorial correlation of postoperative hypocalcemia after extensive thyroidectomy. So what they did is they took patients who had their thyroid removed, and they're hypocalcemic, which is one of the things that drives a lot of the signs and symptoms in hypoventilation, the calcium being driven into the blood proteins. So they said, we know these people are absolutely hypocalcemic. So what are the clinical presentations of these people when we know that they're hypocalcemic? And what they found is Chivas Text sign, paresthesia, and Trousseaus sign are the big ones. A little bit of myalgia, which means discomfort in the muscles or pain in the muscles. And we'll talk about Chivas Text and Trousseaus. We already talked about what paresthesia is. So let's talk about those. The carpopedal spasm I've talked about, that's the like this. You see the thumb sort of come underneath, the fingers go over, and they'll be sort of turned in as well. People kind of do this sort of a thing. You can stimulate this. Before they actually trigger off to do this themselves, the muscles are ready to go, and you can trigger the muscles to go off by inflating a BP cuff. And when you do that, if you inflate the BP cuff on somebody, you'll see their hand go like this sort of thing as you inflate the cuff. That's called Trousseaus sign. So you're stimulating the carpopedal spasm. There's another thing you can do, which is called Chivas Text sign. And if you tap on the facial nerve roughly around here, like this, you'll see people go as you tap on the nerve, and it stimulates, fires off the facial nerve. And with just that little bit of depolarizing stimulation, their muscles in their face will contract up. So that's something you can test for if you think that somebody might have hypocalcemia. Not only in hyperventilation, but in other cases as well. But with someone who's been hyperventilating, if they're not spontaneously doing it, and if you're wondering if they're getting close to it, give them a bit of a tap on the facial nerve and they'll sort of contract up. So here's a case for you. Classic case. I'm sure most of you who are working paramedics have done something like this. You called to a 17-year-old female whose boyfriend dumped her just before a school dance, and then the CAD subsequently asked another girl to accompany him. Your patient's in the basement bedroom of a private residence. She's distraught, she's sobbing, she's hyperventilating, she's displaying decreased levels of awareness, so she's confused. She's got carpopedal spasm, positive Chivas Text, positive Trousseaus. She's got nausea but no vomiting. What's your treatment approach? Think about it. How do we treat somebody like this? Well, one of the things you may have heard is about breathing into a paper bag. And I've actually seen paramedics do this on the scene. I used to think it was a pretty good idea when I took first aid, but then as I went through my medical training, I realized that having somebody breathe into a paper bag when they're hyperventilating is a very bad idea. Let's talk about why. You may have already done this. There's something that we talk about in physiology called the oxyhemoglobin disassociation curve, which basically is a curve of how well the oxygen clamps onto our hemoglobin. And in normal homeostatic conditions, the oxygen comes in through the lungs, clamps onto our red blood cells comfortably, appropriately. The blood cells travel through the body, and when they find an area that's hypoxic, they say, oh, this place needs a little bit of oxygen. So the oxygen hops off of the hemoglobin, the carbon dioxide hops on in a balanced sort of way, and then the red blood cells go back to the lungs and off-gas the CO2. Under different conditions, the amount or the affinity, the desire for the oxygen to cling onto the hemoglobin changes. If you use, a sort of common analogy is that there's a central factory in a city that has all the workers. And the workers in this case would be the oxygen. So out of this central factory, the lungs, the workers pile onto buses, which is the hemoglobin as it travels around in the blood. They travel around on the roads, which is the blood, and they get to a factory where there's a whole bunch of tired workers. And since they're fresh workers, they hop out of the bus, the oxygen goes into the factory, and the old tired workers, the CO2, come into the bus, and they go around back to the central distribution center where they can have a sleep and get regenerated and turn back into oxygen and come back out. So if you think of, oxygen traveling on the bus, the magic school bus, traveling around this magic city, that's an idea to have. Well, one of the things that can go wrong with this is if you change the condition of the blood. And if you increase the pH of the blood, meaning you make it more alkaline, less acidotic, or if you decrease the amount of CO2 that's in the blood, or the temperature, 2,3 dPg, there's other stuff that does it. But what we're worried about here is the pH and the CO2. As you blow off the CO2, the curve shifts to the left. What does that mean clinically? There's sort of an abstract idea of a curve shifting to the left. So let's take a look at this. Alkalosis, hypocarbia, hypothermia all cause the curve to shift to the left. If the curve shifts to the left, it's going to increase oxygen's affinity for hemoglobin. So if we go back to this idea, what that means is the workers, the oxygen, will get onto the bus, but they'll grab onto their seats and they won't want to get out. So you'll have a lot of oxygen traveling around on the hemoglobin, but when it gets to the cells and it's supposed to get off of the hemoglobin and into the cells, it doesn't want to get out of the bus. It doesn't want to get off the hemoglobin. For me, in my mind, I call this alkalotic oxygen clamping. So as the body becomes more alkalotic, as we blow off CO2, the body becomes more alkalotic because the bicarb's clamping with the hydrogen and taking the hydrogen out of circulation. We become more alkalotic, the oxygen clamps onto the hemoglobin and stays there. And that is, it's known as the Bohr effect. It's not actually the Bohr effect, but it's often called the Bohr effect as well. The Bohr effect is just the other side of it. The Bohr effect is the more acidotic an environment is, the more likely the oxygen is to jump off of the hemoglobin. So if you have a very acidotic environment, it's very easy for the hemoglobin to get off of, for the oxygen to get off of the hemoglobin. But the converse is true too, so people will also call that the Bohr effect. If you call it the Bohr effect, most people will understand what you're talking about. So it will stay on the hemoglobin, and what that means is that our actual tissue, the place where we really need the oxygen, isn't getting enough oxygen. The oxygen's clamping onto the hemoglobin and not getting off, not getting into the cells, and we get into real trouble because our tissues, the metabolism in our tissues makes the cells themselves acidotic and hypoxic. The blood has a lot of oxygen on the hemoglobin, but it's not getting into the cell. So think about what that means. You've got a patient who seems to be breathing a lot. You would think has like a ton of oxygen in them, but that oxygen, because of the clamping, is not getting into the cells. So their tissue is hypoxic. So what's the worst thing to do? The worst thing to do at that point is to get a paper bag and stick it over their face and reduce the amount of oxygen that they're actually getting. The principle is that you'll get them to rebreathe carbon dioxide, and that theoretically should set them back to normal, but you're depriving them of oxygen, and that's a terrible thing to do. Let's take a look at why. Let's continue with the case study that we're doing. On further investigation, it's revealed that in an attempt to kill herself, the patient ingested a bottle of aspirin about an hour ago. So she's taken a whole bunch of salicylate. She's salicylate toxic now. She's gone over 150 milligrams per kilogram, and her body is in a metabolic acidosis as a result of taking that aspirin. So no matter how much you blow and no matter how much carbon dioxide you rebreathe, that person is not going to stop hyperventilating. What they need is oxygen. They need more oxygen in their blood, not so much that it gets onto the red blood cells, onto the hemoglobin, but so that you supersaturate the plasma, which can carry like an extra 2% or so of the oxygen carrying capacity of the blood, and at least get them that. Metabolic acidosis is one of the things. You might have learned the acronym MUDPALS. It's one of the things that causes a metabolic acidosis. So that's what this patient is stuck in. And no amount of paper bag rebreathing is going to bring them back to a normal state where they're breathing normally. In fact, it's going to cause an awful lot of harm, which leads us to the take-home message of this entire presentation. And that is that hyperventilation syndrome, which we define as somebody who is voluntarily hyperventilating or hyperventilating due to psychogenic reasons, so that they're upset, they're emotionally, unhappy or distraught or anxious or something. People jump to that as the first thing. Oh, they're hyperventilating. It's got to be just that they're emotionally upset. And I kind of throw out a big red herring there to lead you down that path by talking about the teenage girl who's been dumped by her boyfriend. So of course it's just hyperventilation, just because she's sad, she's being dramatic and overacting, and she just needs to, become hypoxic by breathing more into a paper bag, and she'll be fine. Never assume that that's the first thing. Always go back to that slide I showed you that has the list of possible reasons, from the environment to the brain to the heart to the body, all those different causes of hyperventilation, and think about those. Don't automatically assume that it's just somebody being dramatic, because it's a really dangerous way to run into trouble. Give these people oxygen by a non-rebreather mask. Let them breathe that. Try to coach them down slowly in their breathing and get them to focus on inhaling as long as they possibly can. So a slow, prolonged inhalation so that the CO2 has some time to build up in their body if that's something that can actually help. But don't take too long with that. If you can't calm someone down and coach them down in about 10 minutes, which is how long it takes to come in and introduce yourself, get the vital signs, do all the therapeutic stuff of putting on the monitor, and because they might have acute coronary syndrome, getting the oxygen on them, which is therapeutic. It helps them feel a bit more comfortable, like something is happening. Talk them down, be calm, use your best bedside manner. If you can't get somebody to calm down within about 10 minutes of your calm therapeutic bedside manner, then you have to assume that it is not psychogenic hyperventilation, that there's something metabolic underneath all of this, and they have to go to the hospital. They have to be checked out properly for all the other things that could be causing the hyperventilation. That's the important take-home message. No paper bag. Give them oxygen. Try to coach them down. You got 10 minutes. Look at your watch. You got 10 minutes, and if that doesn't work, you have to assume it's a deeper pathology than just psychogenic hyperventilation. So, diagnosis of exclusion, search for other causes. Reassure them, low flow oxygen through a mask. Don't necessarily make them hyperoxic, like don't put them on 15 liters, but just give them enough, 7, 8 liters to be okay. Look for the other injuries, and if they can't self-correct in under 10 minutes, assume an ominous condition and transport them for definitive long-term assessment and treatment. That's it. If you have any questions, feel free to leave them, as always, in the comments underneath. I do regularly check the comments. I get an email if somebody's commented, and you'll see I usually respond to it. I hope that helps. Be prepared to challenge some other paramedics on the road who pull out the paper bag, or even more horribly, the plastic bag. I've heard about that, never seen it. But if you can remember that flow chart and the causes of all the symptoms that you're seeing, you can make a reasonable argument as to why you shouldn't be using a paper bag out in the field and why you should be giving oxygen to somebody who, ostensibly at least, looks like they should be getting too much oxygen. I hope that helps.